comprehensive neurogastroenterology and motility program to provide multidisciplinary care. A comprehensive neurogastroenterology and motility program provide care for a variety of symptoms related to altered motility and sensitivity throughout the GI tract. These may include foregut symptoms of the esophagus, stomach, and small bowel, hindgut symptoms of colon and rectum, symptoms related to a variety of disorders of gut-brain interactions, such as IBS and functional dyspepsia, as well as other symptoms related to more systemic disorders that might interact with GI tract function. The clinical services of a neurogastroenterology and motility program is usually consisted of two main components: the inpatient and outpatient consultation, including the outpatient clinic, as well as the GI Motility and Physiology Lab. Patients may come in from either component and be referred to the other side, and patients can be coming in either through GI providers or referred from non-GI providers. Patients may come into clinic and we might then schedule them for testing at the lab, or they may be directly referred to the lab, and if they have, depending on the finding, be referred to clinic for further management by us. For a comprehensive motility and physiology lab, there are a number of studies that should be provided, a number of different testing that should be provided. Esophageal function testing often comprised of the most significant component of tests being performed in these labs. These may include high-resolution esophageal manometry for assessment of esophageal motility, as well as a variety of reflux monitoring tests for gastroesophageal reflux disease. These may include the catheter-based pH or combined pH and impedance monitoring, or a capsule-based Bowel pH capsule. And depending on the patient population, there are also a variation of these catheters that may allow assessment of extraesophageal reflux, such as laryngopharyngeal reflux. Interrectal motility can be assessed through the high-resolution interrectal manometry and physiology testing. They include balloon expulsion testing. The wireless motility capsule allow assessment of transit time throughout the stomach, small bowel, and colon after ingestion of a wireless capsule. Some breath testing may also be offered, including H. pylori breath testing, testing for small intestinal bacterial overgrowth, breath testing for a variety of carbohydrate malabsorption, such as fructose, galactose, and lactose malabsorption. And there's also actually a breath test that can be performed for gastric emptying as well. So these often is also an important component of the motility and physiology lab. There's some other studies that may also be offered. The flip pneumometry is a newer technology that's done through endoscopy for assessment of lower esophageal sphincter distensibility, as well as secondary peristalsis of the esophageal body. Intraduodenal manometry assess the peristaltic and contractile function of the stomach and small bowel. It is not really commonly performed these days because the catheter actually require endoscopic placement. Similarly, for colonic manometry, it's not really done in adults much, mostly for kids. It needs to be placed endoscopically, but it allows also assessment of the peristaltic and contractile function of the colon. In providing comprehensive care in a neurogastroenterology and motility program, there are a number of other supportive components that are needed in order to properly evaluate and manage these patients. And these include endoscopy, specifically interventional endoscopy for all of the diagnosis and treatment of these conditions. Radiology, there's specific protocol for specific tests that are used for assessing GI tract motility. Having qualified and specially trained dietitians, gastro-psychologists, physical therapists, as well as speech language therapists are also important parts of a comprehensive neurogastroenterology and motility program. And I'm going to talk about each one of them specifically. For endoscopy, the number of diagnostic testing that could be done, we talk about flip pneumometry, where we can assess lower esophageal sphincter distensibility, diameter, as well as the secondary peristaltic function of the esophageal body. It is becoming more and more important as part of the diagnostic algorithm for esophageal motility disorders, specifically achalasia. Wireless pH monitoring is performed through endoscopy, as we talked about, as well as the intraduodenal manometry. But most importantly, the therapeutic component of endoscopy is important. Dilation, including pneumatic dilation, is an important part for treating some of these motility conditions, such as achalasia. The flip technology actually can also be used for dilation up to 30 millimeter. Botox injection, whether it's to the lower esophageal sphincter, the pylorus, or the anal rectum, may also play a role in managing a variety of motility conditions. POEM, which is peroral endoscopic myotomy, involve endoscopically tunneling into the muscular layer, and during the myotomy of the lower esophageal sphincter, it has been shown to be effective in treating achalasia. Variation of that called the G-poem involved tunneling into the pylorus and doing a myotomy of the pylorus. These have been shown to potentially be useful for a subset of gastroparesis patients, although more data is needed. Endoscopic ultrasound may also be useful because it allows you to assess the deeper muscular layer of the GI tract if needed. And also feeding tube placement, because some patients with more end-stage motility disorder and nutritional deficiency, feeding tube may be needed for continued management and maintenance. Radiology is an important part for diagnosis and monitoring of patients with motility disorders. And there's specific protocols we use for these purposes. With barium esophagram, the important protocol that we need to make sure that it's available is the time barium esophagram protocol. It involves ingestion of 100 to 200 cc of liquid barium, and spot films are going to be taken 1 minute, 2 minutes, and 5 minutes after ingestion of barium. The radiologist can then measure the column height at the different time point to determine how well the esophagus is emptying. And it has been shown to be useful in diagnosing and monitoring of achalasia patients. Gastric emptying scintigraphy is important in management of patients with potential gastroparesis. It's important that the standard 4-hour study protocol is used. It is currently considered the gold standard for scintigraphy. In this protocol, anything more than 10% retention at the 4-hour time point, or less than 90% emptying at the 4-hour time point is considered abnormal. Cyst marker studies are useful for assessing colonic transit. Patient ingests a capsule with cyst markers, and a plain film is taken 5 days later. By counting up how many cyst markers still remain in the colon, one can determine whether or not there's abnormal colonic transit. Echocardiography is important for assessment of pelvic floor function, as well as function of the puborectus muscle and the anal rectal angle during defecation. These can be performed either fluoroscopically or through an MRI, and can allow diagnosis of dyssynergic defecation or other pelvic floor dysfunction. Upper GI series and small bowel follow-through may also be helpful, especially you can sometimes ask the radiologist to assess small bowel transit time or oral cecal time of the barium to give you an idea of small bowel motility. There's some other newer technologies, such as whole gut scintigraphy, that might become useful, although currently it's not widely available, and there's no well-validated normative value for that at this point, but it may become useful technology in the future. Having a qualified dietitian is important because we know that dietary intervention is an important component and treatment option for management of a variety of motility disorders or disorder of gut-brain interaction. These may include simple dietary modification for reflux, for gastroparesis, or constipation, but there are also a variety of elimination diet aiming to remove the potential symptom trigger, for example, the low FODMAP diet or low carbohydrate diet. And these dietary interventions are often complex, so having a qualified dietitian to help guide the patient is important. And preferably, dietitian is well trained and has expertise in motility disorders and disorder of gut-brain interaction. And longitudinal follow-up is important because, especially for a lot of these elimination diet, this need to be followed by the reintroduction phase where patients reintroduce specific food, and so that they can personalize their diet later to see which one they can tolerate. And having guidance from a qualified dietitian often really ensures success of these dietary interventions. I know there'll be a talk about gastro-psychology later, so I'm not going to go into a lot of details, but we know that psychiatric comorbidities and hypervigilance play an important role in symptom severity in patients with disordered gut-brain interaction dysmotility. And a variety of psychological and behavioral therapy have been shown to provide benefit in treating these disorders. This may include cognitive behavioral therapy, gut-directed chemotherapy, or diaphragmatic breathing. Having a GI trained psychologist to provide these therapies is going to be essential for a robust neurogastroenterology and motility program. Physical therapy is also important because of potential pelvic floor dysfunction and dyssynergia. We know that dyssynergia, sphincter dysfunction, altered sensation, or other defecatory disorders are important etiologies of a variety of hindgut symptoms such as chronic constipation, incontinence, proctalgia. They have also been associated with chronic abdominal bloating discomfort. And pelvic floor physical therapy and biofeedback therapy have previously demonstrated efficacy in managing these defecation and anorectal disorders. So having a well-trained pelvic floor therapist is essential, especially in managing these patients with hindgut symptoms and dysfunction. Speech language therapy is also important. We know that in evaluation of swallowing symptoms, we often focus on esophageal-based as gastroenterologists. We know that any oropharyngeal dysfunction may also lead to swallowing symptoms by the patients. And these speech language therapists can provide comprehensive evaluation through using technology like the video fluoroscopic swallow study to assess any oropharyngeal dysphagia. Another option that they may employ is the fiber optic endoscopic evaluation of swallowing, or the FEAS, where they essentially endoscopically visualize a patient swallowing certain test food and see if there's any signs of retention, aspiration, or penetration. And it's important that these speech language therapists not only do the assessment, but also provide therapy if needed for any dysfunction that they identify. We know that there's a lot of interactions between GI tract motility and sensitivity with a variety of systemic disorders and dysfunction. Therefore, there's a lot of collaboration between a comprehensive neurogastroenterology motility program with other subspecialties. And these may include pulmonary and lung transplant physicians for patients who may have extraesophageal complications of reflux, surgeons, either thoracic, GI, bariatric, or colorectal surgery for management of motility of these conditions. We may actually also manage patients who develop symptoms after surgery. Rheumatologists, allergists, and immunologists are important because we know a lot of immune-mediated conditions may be associated with GI tract dysfunction. Endocrinologists, especially for patients with diabetes or thyroid dysfunction. Oncology, particularly patients that develop symptoms as a side effect of their oncology cancer treatment. But patients may also develop GI tract dysfunction or dysmotility as a part of a complication from the primary cancer, like peritoneoplastic syndrome. Working with neurologists is important because we know that a lot of autonomic dysfunction, neuropathy may be associated with GI tract dysfunction. Anesthesia and pain management can help manage a lot of patients with refractory symptoms, primarily pain-driven symptoms. We talked about how psychiatric comorbidities are important, and a lot of times by managing these patients, we use neuromodulators that overlap with a lot of psych medications. So having a relationship working with them and managing these patients is also important. Working with otolaryngologists is also important because of a lot of swallowing symptoms patients may have, also for evaluating for any extraesophageal complications of reflux, such as laryngopharyngeal reflux. There are also a number of other considerations we should have when building a program. For outpatient clinical care, consider building specialized multidisciplinary programs. These may include examples may include a comprehensive GERD program where you collaborate with ENTs, pulmonary physicians, thoracic general surgeons, maybe interventional endoscopists because of some of these newer endoscopic and reflux treatment, and nutritionists to provide to build maybe a multidisciplinary clinic where patients can have sort of one-stop shopping for seeking care. An EOE program may include allergists, nutritionists, or pediatric providers for eosinophilic esophagitis. A colonic or anorectal program may include also colorectal surgeons, urogynecologists, and pelvic physical therapists to provide comprehensive care. Because motility disorders and also disordered gut-brain interactions often are hard to evaluate from a symptom standpoint and monitoring symptom severity, having standardized patient-reported outcome measures are important. These may include employing validated symptoms tool when patients come to clinic or procedural visits. You may easily also consider using some of these newer technology or apps that patient can use to enter their symptoms to monitor their symptoms from home. A coordinated and protocol-driven care with some of the supporting services we talked about also important to make sure that we have a very standardized approach to these patients. Some considerations for the motility lab from testing and procedure standpoint, having direct referral through the electronic medical record system for testing will be helpful to help reduce any error in the referral, especially when other providers are directly referring patients for testing. Having comprehensive testing information and instruction for patients is important because a lot of time, a lot of non-motility providers are not very familiar with these testing and may not be able to tell patients what to expect. There are a lot of materials that you can consider using that are prepared by professional societies, such as the American Neurogastroenterology and Motility Society, to provide for patients. If your center has multiple providers that might be interpreting these tests, standardizing motility testing or procedure report is important. Try to use consensus algorithm whenever available, such as the Chicago classification for esophageal manometry, and unify the format of reports across providers may help ensure the quality of these reporting and these studies being done. So as you can see, we quickly went over how to, what the different components of a comprehensive neurogastroenterology and motility program. And you can see that there are a number of supporting services that are required to internally use the program, as well as a number of other subspecialty that our program need to collaborate with to provide true multidisciplinary care for patients with these often debilitating symptoms. Thank you.